Thank you. Hi, everyone. Good afternoon. Thank you for joining us at this odd time. I hope everyone's having a good Tuesday, and we'll get started in just a minute. Great. Thank you, Aaliyah. All right. And as folks continue to trickle in, we will just keep it moving. But welcome everyone. We usually hold this meeting on Fridays, but due to conflicting time with CCHP's Community Supports office hours, we will be changing the time of our CPI meetings for Contra Costa moving forward. Today, they will not always be Tuesdays at 2 p.m. This was just kind of a last minute time that worked. And we'll go over the new schedule moving forward. So this is our agenda for today. As you are joining, I see some new faces, so please feel free to put your name, your organization, and something you like to do in spring in the chat so we can all get to know each other a bit more. So today we'll go over some updates. We have quite a few, some events that we hosted recently, some new one-pagers that we have, and then just a couple of DHCS updates. And then I will pass it off to Lene to give us a Contra Costa County JI presentation, along with some folks from RDA consulting firm. And then we will do a data exchange framework overview hosted by Deanne, who is a consultant with us at Intrepid Ascent. And then we'll do some closing. It is a packed agenda, so I'm hoping we can get through all of it. And if not, you'll get it all in follow-up anyway. Are there any questions before we get started? Nature hikes. Shaneway, I love the wildflowers too, but has anyone else been experiencing allergies? It's like day one of spring, I start sneezing, but I love it. There's been a lot of poppies around. Very cool. Baseball games. I don't know baseball. I assume baseball is a spring. Is that a spring sport? I don't know. Very cool. Thank you, Deanne. Awesome. So as folks are joining, you can feel free to continue introducing yourself in the chat, but we will get started. So we'll start with some updates. There are a few. We've been talking about this. We talk about this every time we meet. As a reminder, the Path Cited Round 4 application has been extended and is now due on May 2nd. And before that time, there are still a couple of DHCS Path Cited Round 4 office hours that they're hosting. There's one on the 27th of this month, and then April 10th, 17th, and 24th. And they have on their website the registration links for all of the office hours. I'm happy to send them out as well, but the reason I didn't put them on the slide is because it's a different registration link for each of the office hours, and I didn't want to overwhelm us. Again, cited round 4, the application opened in January. It was supposed to be due in March, but has been extended now to May 2nd. This just on the screen just gives the highlight of the eligibility and then the priorities for Path Cited in general. Okay, a lot of words on the screen, but on February 26th, we actually held a CalAIM 101 session that was specifically geared towards folks that could be referrers for the children and youth populations of focus. So that was really, I did targeted outreach to the school districts in Contra Costa County, and then CHWs and other folks that work with that population of focus that could, in theory, be referrers. I did cold outreach. It was pretty crazy. I did cold outreach to every school in the county that is across 18 districts, hundreds of schools. We had 47 people sign up and actually 23 attending. And the makeup of those in attendance were generally mostly community schools coordinators. So those are folks that actually are working at school sites, helping families navigate, and care coordinators. So those were also contracted ECM and community supports providers as well. There are a lot of next steps coming from this, especially as we know that the children and youth populations of focus are a huge priority area for both Contra Costa County and statewide from DHCS. So we do plan to host this event for parents at an elementary school in Richmond that did reach out and wanted to know if we could do kind of a coffee chat version of that. And this potentially could be happening at other schools as well. We're also going to be hosting this session for EHSD's CPP planning team. And if anyone is on the team, correct me if I'm wrong, the Comprehensive Prevention Planning team. That is a group of stakeholders throughout the county that work together to create a countywide prevention plan to support children and their families. And then this is so exciting to me. We are actively working with a middle school in Richmond to do kind of a PDSA type test of change to create a school site CalAIM referral workflow. So that is really exciting. I feel like I say this all the time. I used to be a teacher in Contra Costa County, so this is what fuels me and excites me. So we have a lot of momentum going on in the children and youth space. And I want to make space here if there are any questions or if anyone else is focused on increasing children and the youth utilization of CalAIM services in the county. We're really curious to know what those activities look like, if any. Is there anything that we can do to support as the CPI facilitators in the county? So I want to leave a little space for anyone that wants to share or come off mute or in the chat. I think that's a hand raise. I can't tell. Go ahead. Please feel free to come off mute.
It is. Hello, everyone. My name is Crystal Ayub. I'm a registered dietitian. I work across organizations. I'm part of Umoja Health. We are contracted to serve adults with food as medicine services. And then also I'm working with Ujima, a nonprofit organization with statewide reach that will be delivering medically tailored grocery boxes and medically supportive foods to children and youth with diabetes and obesity, targeting those specifically in the school system, unhoused, coming out of the criminal justice system. And we are currently in development of our bidirectional workflows as well to work with community-based organizations that have pop-up pantries and other sites already embedded within the school system.
That is so cool, Crystal. I didn't know, you might have shared that at the symposium, but maybe it didn't register for me. That is really cool.
Yeah, we're really excited. We see that there's a huge need for this. Ujima, our sister organization, as I mentioned, is a nonprofit, significant experience, 20 plus years of experience working in child nutrition programs across the state. So working within those nutrition requirements, getting to know those students, their taste preferences, menu development. So really excited to collaborate with them to enhance the services that are being delivered under CalAIM, and happy to have any additional conversations if you guys are also working within those schools and school districts, because we will also be doing that as well.
That's very cool. Thank you, Crystal.
You're welcome.
Yeah. The children are at the schools. That's where we should be finding them. I think it makes complete sense.
Exactly. And I do know from experience talking with the managed care plans, we're dealing with some other challenges with children and their families and being trustful of the schools. I know ICE has been to some of the schools. And so for those families that are not comfortable sharing maybe a physical address, then maybe that physical address is the school site. So working with those schools, those nurses, those dietitians will be really important. And so happy again to have those conversations because we are just dipping our toes into this right now, but really excited to keep pushing forward.
Thank you so much for sharing. Yeah, I was going to say, Crystal, can you put your contact information in the chat? I think there are folks that are interested in learning more.
Absolutely.
Thank you. I like to make space for anyone else that wants to share, and you are also more than welcome to put it in the chat or let us know after the fact and we can send something out and follow up. Okay, hearing nothing else, I will continue us on. We also, on March 14th, hosted a Food as Medicine by CalAIM Symposium event in person in Richmond. So we had 22 attendees that represented 15 unique organizations within the food ecosystem in Contra Costa County, and that's both within CalAIM and outside of CalAIM. And really the point of this symposium was to host sessions and activities around seeing and understanding the food ecosystem in Contra Costa, again, both in and outside of CalAIM, seeing where we can make those connections and pipes together because we know that CalAIM does go away in 2027. Really envisioning what the ideal state of the food ecosystem looks like in the county and brainstorming around how we might be able to pursue those ideal states. So next steps from that, we are, if you can imagine, 4 hours of activities. There's a lot of sense making and a lot of data analysis going on. So we do plan to continue doing that and then sharing back out with the collaborative about symposium findings in an upcoming collaborative meeting. And we also heard that there is interest across the food providers to host more in-person symposiums this year. They are not yet planned, but we do foresee that happening. And so there's a lot of momentum going on in Contra Costa County around children and youth and the food spaces. So we've done some really exciting work. Um, And then again, these are some of the main kind of how might we questions that we thought about in that food symposium. And again, I want to just pause here for a few brief moments and see if anyone has any thoughts or anything you would like to share regarding the food space, helping folks step on or step off from MTM to other more evergreen services like the food bank. So curious if anyone has thoughts.
While folks are thinking, hi, I'm sorry I was a little late. Lauren Panaccio, she, her, a pronoun series. I facilitate this with Hannah, although these days I more just make sure I get out of Hannah's way. Um, Sorry to be in your way for a second here, Hannah. I just want to offer, first off, for those that were able to join us, like it just felt really special to bring everybody in person and to see one another and your services. And I also want to give a shout out, thanks, and help you all hold us accountable to pulling this through, which is we actually surrounded the room with overviews of every food service provider that was in the room. And we actually want to share that out. We heard that even in the peer of Contra Costa County food providers, there was so much new information that was like literally surrounding us as we tried to answer these questions. So to Hannah's point on there's a lot of, we call it sense making, that's part of it. And so I want to name that we'll share that out. I know Blanca from Crisis Center who runs the 2-on-1 is on the phone. That I think will be particularly potentially helpful to you, Blanca, but also to others to get really specific on the food services. And then each of these kind of how might we's, there's 3 of them that to Hannah's point on the screen. I think the room did a lot of good thinking against each of these. And so we're excited to bring that back to you all. But just wanted to name and appreciate just how much was shared in that room. And again, to Hannah's point, the type of stuff that'll come back to you all. So we hope that that's an infusion towards some of these 3 questions. But to Hannah's point, want to make some space for folks that weren't in the room that have thoughts on any of these questions or any other questions that feel really pertinent at the intersection of food security and CalAIM that maybe we didn't think about yet.
Thanks, Lauren. And of course, sometimes, at least for me, I need some time to process before coming up with questions. So in a few minutes, if you do have things that come to mind, please feel free to put them in the chat. Um, Crystal, you can feel free to come off of mute. You don't have to raise your hand.
Yeah, I just wanted to piggyback on what Lauren said and what you guys were saying about the Food as Medicine symposium. I'm really grateful that you guys held it. I've been to CPI work groups and different things all across the state. I think this one was especially engaging, which was really nice. And there was a lot of excitement. For me, I think the biggest takeaway was that there are many community-based organizations that are not contracted Calian providers, and they are a great resource currently and to help those members transition off of these services. And so that was my most important takeaway, is the ability to work with those community-based organizations and let them know, even though they may not be delivering Calian services, there are still referral pathways and ways we can work together to make an even bigger impact in their communities. So thank you, and I look forward to the next one.
Thank you, Crystal. We appreciate having your voice in these spaces. Okay, I can move us on then. But please feel free to come off mute and interrupt me if you so choose. So now a few resources that we have created. Some of you may know that we've been working for a few months now on a medically tailored meals, medically supported food one-pager, really a provider overview for those contracted in Contra Costa County. This is version 2, so this updated version is on our Contra Costa PAC CPI resources page. I will also send it in follow-up because our page is a Google site, and I know sometimes Google can be a little bit funky. Thank you, Aaliyah. Aaliyah put the site in the chat, but if it doesn't work, you will get this in follow-up. And again, just a call out that if there are any contracted MTM, MSF, medically tailored groceries, there's a lot of new acronyms, on the call in the county and you are not represented on this one pager, please feel free to reach out. We want to make sure that it is as comprehensive as we can make it. Yeah, so let me know if you have any questions around that. It does display a lot or all of the new updated definitions that were dropped by DHCS, and we'll go over those as well briefly in a couple of slides. And then we have another resource that I want to share with you. It is a closed loop referral one-pager that we've created to kind of give an overview of the closed loop referral requirements and the key changes to those requirements, keeping in mind that MCPs are required to implement these closed loop referral requirements starting on July 1st of this year. So that resource as well is on our PAC CPI website, and we'll also go out and follow up. We do also plan to have kind of a closed loop referral, a more focused talk about closed loop referral requirements in an upcoming CPI meeting. So there will be more information on that coming soon. And then lastly, just to circle back on those definitions that I mentioned, DHCS in February dropped some new updated newly released updated service definitions for 4 community supports, namely nursing facility transition, community transition services, asthma remediation, and medically tailored meals, medically supported foods. These new changes do go into effect on July 1st again of this year. And DHCS has said that they plan in the spring dropping new updated service definition refinements for the housing trio as well. Those are not out yet, but we will be the first to let you know when they do. And then just to zoom in on the medically tailored meals one, especially because there's a lot of energy around the food ecosystem in the county. We know that medically tailored meals, medically supported foods provide targeted food and nutrition services to members that have nutrition sensitive health conditions. And so those meals and that food is specific to that member's eligible condition. They've broken it up into kind of 3 categories now. So there's medically tailored meals and medically tailored groceries. So those 2 medically tailored pieces do require an individual nutrition assessment that is conducted or overseen by a registered dietitian nutritionist. And then medically supported food is not medically tailored, so doesn't require that nutrition assessment, but there are now categories that fall under this umbrella of medically supportive foods, and that includes medically supportive groceries, produce prescriptions, healthy food vouchers, and the food pharmacy. And I don't believe this service changed, but the service covers up to 2 meals and/or meal packages per day, and that's using a combination of medically tailored meals and medically supportive food. And those can be authorized for up to 12 weeks and may be reauthorized as necessary. Are there any questions or any thoughts around this? And Lauren, if there's anything you want to share, I don't know. Some changes to those service definitions.
The
I
one
have,
question,
oh, sorry.
oh, that's okay. I was just gonna say the one question that came up in the room that's smart, and so I'll just re-elevate is under that annotation under item number 3 of what's considered a medically supportive food. I just want to be super clear that those are types of medically supportive foods. You don't have to provide every single one of those to say you provide medically supportive foods, because doing any one of those things can be a full-time job as an organization, nonetheless, all of them. So I thought that was a really smart question. Hannah, we should probably update the slide so that's even clearer.
Yeah.
But just want to make sure to elevate that and not get folks nervous. I feel like I spend all of my time doing supportive groceries. What do you mean I have to do this other stuff? You don't. Sorry, I stepped on somebody though accidentally. So whoever was speaking, please continue.
Just Crystal. It's fine.
Go ahead,
I just
Crystal.
wanted to, might not be the right space, but I just wanted to quickly elevate. I do have some concerns past the service definitions, but really on the monitoring and auditing piece that's in the last page of the policy guidance. I myself have numerous meetings with various health plans all across the state every week, and I can tell you that there is huge variation in the interpretation of the auditing and monitoring requirements. I think for larger CBOs and other organizations, this becomes incredibly problematic because we serve more than 30 counties. So what is considered, we just can't, like as providers, having different nutrition requirements for every managed care plan is incredibly challenging. And I'm just making this up. Let's say one managed care plan wants 700 milligrams of sodium or less, and another one says, well, I'm using a different evidence-based standard and I want 500 milligrams or less. Does that mean I can no longer serve meals or groceries in that other county because I don't adhere to whatever their standard is? And so I do think it's important to note that while it's great to have 2/3 requirement per meal or per package, what those thresholds mean and the standardization of that and how they're submitted has not been shared with us. And I think that's going to create a lot of burden on the actual providers. And so would love some feedback either now or down the line on how DHCS and or the managed care plans plan to standardize this, because right now I'm getting managed care plans that every single suggestion on this page, they want every single one of those. And some of them want none of them. So not sure exactly how to like push through that, but would love to continue that conversation when appropriate.
Yeah. Appreciate that. If you hear our team typing, it's probably because as we've shared previously, part of our role as CPI facilitator is to be an intermediary between ground truth and what's happening at the state level. This is not the first time we've heard like a new definition, and now we're like trying to figure out how do we, we thought it wasn't interpretable, but now it is, and what degree of interpretation and where is their interpretation? So Hannah and Aaliyah, let's make sure that we elevate this as a question from the field and a suggestion to the state. And again, if to Crystal's question, if folks have other experiences or kind of best practices around how to navigate the current state, please feel free to, we believe in collective intelligence. Please feel free to offer that, but just to appreciate that. One, two, not surprising. It happens when new definitions rolled out. And three, a reminder that we do our due diligence in elevating things up to the state, and we can absolutely do that.
Thank you. And Aaliyah, can you also make sure that we're collecting the questions that are coming into chat?
Yes.
Because Leslie, that's a good question, and Lauren, don't know if you have an answer or would know the direction.
Yeah, I think it depends on I think it depends, right? It depends on how the MCP is, like what requirements there are, to Crystal's point. Like if the requirement is all medically tailored meals have to be frozen, I'm making that up. That's a whole different can of worms. Or if you have to deliver to the place of residence, that's a whole different can of worms. So um uh yeah, and I think each or a contracted agency is creating a strategy and or figuring out if there are specific populations of focus they can or cannot serve. And just a reminder that those that are homeless is it's a special population to try to care for. I don't know, Michael, if you want to share a bit more about what you all are seeing and experiencing. I'm sorry if you can't chat. And I just called you in.
It's a very graceful.
What is the question? I'm so sorry. The unhoused. Michael, I'm gonna let you tackle this one.
And or if there's anyone who's also a housing trio or ECM provider. Mike, did you just come off mute? I also just think I shortened your name. Sorry.
Hey, I respond to hey you. That works. So yeah, real quick, I will say that we are contracted with Contra Costa Health Plan to provide a pretty unique solution that fits under the food as medicine kind of umbrella within the state of California. But it's really a solution that can be put in a backpack or a shopping cart or a small satchel that can be carried, to anywhere. But it is a shelf-stable solution that Contra Costa has allowed us to contract for, specifically to provide a food solution for the unhoused. What I will say is that is not medically tailored as our normal medically tailored grocery boxes are at Umoja, but it is a solution to provide kind of that 2/3, more of a medically supportive food definition, where it supports 2/3 of kind of just general daily nutrition for somebody who's unhoused. It's extremely hard. And trust me, we're looking at it. We've got a bunch of people looking at this right now into bringing a true medically tailored solution to the unhoused, but it's much harder and much more complicated than most people think. So that's what I've got. But just want to say that there's a solution out there for the unhoused population. The biggest challenge, to be honest with you, we fielded several of these calls from health plan partners across the state, is that ultimately we do need an address, right? And now that can be an FQHC, that can be a case manager's office in some cases. It can be a family friend, somebody that they have built some rapport with. So we do usually leverage an address within the community for those people who are unhoused. So it presents its own challenges, as you can probably guess, but that's how we're solving that today. Hope that helps.
Thanks for sharing, Michael and Crystal. That's really cool. Okay, I'll move us along. Thanks for that question, Leslie. That's a really good question. So now I would like to stop doing the talking and pass it off to Lene and her colleague or RDA consulting partners to give some updates on the JI initiative in Contra Costa. Lene, just let me know and I can click through the slides for you.
Okay, sounds wonderful. Thank you, Hannah. Hi, everyone. We are back with a couple more updates for CalAIM JI. Before I pass it over to my colleagues Jamin and Fabian from RDA, I wanted to quickly just do a quick refresher about the CalAIM Justice Initiative. So we in Contra Costa County have gone live. There's a couple elements to the reentry initiative, the CalAIM JI reentry initiative. The first was required to go live in January 2023 and was the pre-release Medi-Cal application process. So our county detention facilities are active and live with supporting individuals that are incarcerated with completion of Medi-Cal application. We've also instituted a real-time eligibility check that goes through our EHR to identify if they come in with Medi-Cal insurance. And if they do not, then we support them with that application if they are in fact eligible. So that is live, and we have been live with that since January 2023. The other thing that our county recently went live with in October 2024 was behavioral health linkages. So any county or CDCR state prisons, for example, that had gone live with pre-release services, our county behavioral health program is receiving behavioral health linkages, so referrals from those counties. As of last week, they had not received any referrals. There are about 4 or 5 counties that are live now, one including the CDCR state prisons, but many are coming live in the next couple months. So I'm sure we will see some more referrals come in shortly here. What we are going to talk about today is the pre-release services. So those are the services that will be offered to those individuals incarcerated 90 days prior to release. So these are all pre-release services. And as a reminder, our county, Contra Costa Health and Contra Costa County, will be going live with the pre-release services in October 2026. So this presentation that RDA has done for us and all the data collection and capacity assessment that they have done is really holding the space for what does it currently look like, what are the services that are offered, who are the players, and that's kind of what this presentation is looking at as we go into the planning phase and designing phase of the Justice Initiative and the pre-release services. I do want to just give one caveat. There are some service maps and such that we have scoped. We may be missing entities that are serving these populations. If that's you or you know of them, please drop them in the chat. We are actively, as we present this, open for feedback to get any other providers that we may have missed or did not capture. So please don't be shy to offer that feedback as well. Okay, I will go ahead and pass it over to Jamin, and we can go ahead and get started. You can go to the next slide, Hannah.
Thank you, Lene. Hi, everyone. My name is Jamin Franklin. I am a senior consultant at RDA Consulting. And we, as Lene mentioned, have been part of the health. We work on a capacity assessment for the CalAIM Justice Involved Initiative. So you can go to the next slide, actually. Thank you so much. So this is our team. My colleague Fabian and I are here today. So he's been working as the quantitative analyst on this project. And the project manager, we also have Courtney and Emmanuel, our other colleagues who can't be here today. You can go to the next slide. Thank you. So this is our agenda, what we'll go over. So we're going to go over an overview of the initiative and our work on the assessment, overview of the population needs in Contra Costa County. Then we have some data on the current system capacity, and then we have some findings from some service provider engagement interviews, and then our Q&A and discussion. Next slide. So a little bit about the initiative and the assessment. You can go to the next slide. Thank you. So many of you may know, but as Lene mentioned, so the CalAIM Justice Involved Initiative is a California initiative. California is the first state in the nation to provide Medicaid services for up to 90 days, pre-release individuals in prisons, county jails, and youth correctional facilities. And the purpose of this is to improve pre-release care and post-release service continuity. As many of you may know, historically, many individuals lost healthcare coverage upon release. So this would lead to gaps in care, higher rates of untreated conditions, and increased recidivism risks. So this initiative creates a structured, proactive approach to addressing these longstanding challenges. So there are 3 initiative. The pre-release Medi-Cal application process, as Lenny mentioned, that ensures eligible individuals have Medi-Cal coverage at release. Then the 90 pre-release services, so that's access to medical, behavioral health, care management, and social services before release, and then linkages to care upon reentry. So those sort of seamless transition warm handoffs to community-based care. So for this assessment, we focused on the first two puzzle pieces in this image. So the pre-release Medi-Cal application process and then 90-day services pre-release. So you can go to the next slide. Thank you. So these are the pre-release services that are currently offered in Contra Costa detention centers. So we have care management, which supports coordination of services for reentry beginning up to 90 days pre-release. Community worker services, so those include any that are covered within the state Medi-Cal plan in order to support prevention of health conditions, as well as navigation of services. And these positions can include community health representatives, navigators, or other community-based public health workers. I'm going to turn off my video because I'm having internet issues today. So, pardon. Hang on one second. And just, I guess, give a holler if I freeze. Okay. All right. Next slide. Thank you. So a little bit about Justice Involved Initiative eligibility. So to qualify for CalAIM services, individuals must meet MEL or CHIP eligibility criteria and belong to one of the groups listed on the slide. So youth eligibility, so any youth under 19, youth who are in foster care or former foster care up to age 26, or any youth in custody of a youth correctional facility. And then adult eligibility is new adults, parents or caretakers, elderly, blind, or disabled individuals, or any adults who have any of the healthcare needs that are listed. So serious mental illness, substance use disorder, chronic or significant clinical condition, intellectual or developmental disability, traumatic brain injury, HIV or AIDS, or who are pregnant or postpartum. And so this is critical because a significant portion of the justice-involved population has behavioral health needs and chronic conditions. So it makes a lot of folks eligible, but they're often unconnected to care. You can go to the next slide. Thank you. So the purpose of this assessment, so we've been working with Contra Costa Health for a couple of years now. So the purpose of the capacity assessment is to establish a baseline of services as they are now. So this is to help inform the county's future program planning to meet the CalAIM-JI requirements and ensure person-centered and accessible care. And again, it focuses on the current service capacity, the eligibility estimates, and where there are opportunities for growth. And just to let you all know, this is not intended as an audit. This was not like an evaluation, but it was just a baseline assessment to inform that future planning. You can go to the next slide. So a quick overview of Contra Costa County and the current state of Mal and detention centers. So Contra Costa County's rate of uninsured residents is statistically lower than that of California. An estimated 4.81% of residents in Contra Costa County uninsured compared to the 6.92% of California residents. The area county's Contra Costa rate ranks fourth highest in the rate of uninsured persons below Napa, Sonoma, and Solano. And then the next slide shows the average daily population in the 4 detention facilities in the county. So this is just to give a sense of overall volume. There's over people in detention in the county. Next slide. So these are the services that are aligned. Oh, I think maybe that one came out. Sorry. Okay. So we worked talking to a lot of the providers in the county to put together some system maps. So you can go to the next slide. And so these system maps were built through a collaborative effort. The information was mainly sourced from stakeholder interviews, where folks shared the referral pathways and relationships they have within the system. These are intended to provide a reflection of how the continuity of pre-release services show up as a snapshot. A limitation to note is that this is mainly documenting the pre-release partners who were able to attend the interview sessions and those who were part of the work group, which is the pre-release work group. So it included stakeholder interviews, conversations with several agencies from justice, healthcare, and community-based organizations to capture service pathways and their relationships. Once we gathered the info, we went through a few different iterations of reviews with Lene and her folks at the CCH team. So this was to ensure that the maps align with the current workflows and the goals of the CalAIM JI. So there are two separate maps. There's one for adult and one for juvenile, just to recognize that the system and reentry needs differ between these populations, and that they are delivered slightly differently, but they look pretty similar. So we can go to the next slide. So just a couple of key design elements to point out. So down in the bottom right, there are color-coded categories. So these program categories distinguish the key service sectors. So we have justice, healthcare, additional county services. And then to the left of that, we have these icons that show which support services are offered by each of these partners. So moving up to the left-hand side, we have these horizontal sort of swim lanes that mark justice, behavioral health, physical health, and reentry transition support. This separates the agencies by function domains to show how different sectors interact in a stack. The map flows from left to right, so attempting to mirror the movement from incarceration to reintegration, or in other words, pre-release to post-release. So also, many of these partners provide services in both pre-release and post-release, but we tried to show partners where they first would interact with a client. So if they first interact with a client in pre-release, but they continue to post-release, they're going to be shown in pre-release. So the next one is the juvenile services system map. Great, thank you. So again, if anyone in here thinks that your work should be reflected on these service maps, please either put it in the chat or reach out to us. I'll put our emails in the chat here. So in the pre-release phase, multiple agencies, including detention teams and behavioral health teams who conduct intake assessments, Medi-Cal enrollment, and coordinate initial care planning. And then there's sort of the transition phase, which is kind of a spectrum in the center. So as release approaches, specialized reentry programs like Game Plan for Success, which is part of the Office of Education, and community-based organizations are engaged with warm handoffs, ensuring immediate connections to essential support services. And then typically reentry support function, providing direct support through a variety of services indicated by the icons. And then moving down to the right, we have the post-release phase. So these partners focus on stability, addressing individual needs through housing assistance, healthcare, or peer supports, while maintaining some level of ongoing case management to minimize recidivism. So I just want to pause for a moment to see if there are any questions about this. And I know this is like a lot of information. We're kind of running through it pretty quick, so. All right, great. I will pass it off to Fabian to go over our data methods.
All right, so as Lene mentioned, we looked a lot at service data, a lot of internal CCH data, and so this section is really dedicated to that. So feel free to go on to the next slide. All right, so first, RDA and Contra Costa Health collaboratively identified key goals for the capacity assessment and sought to align them with both internal and external available resources. And the goal here really was to align historical trends with some proxies for the CalAIM Justice Initiative eligibility criteria. And so here are some data resources we use for context, but that said, the majority of the data that you'll see today will reference internal Contra Costa Health Service data. Feel free to go to the next slide. And so throughout this section, it's important to keep the following elements of data in mind. So for the vast majority of our figures or tables, unless I specify otherwise, the key unit is actually going to be booking. And so the rationale behind this recognizes that although the same individual could be booked more than once, healthcare criteria could also change. And so additionally, each booking goes through the same intake process. The sample incorporates bookings that took place from January 2022 to the end of September 2024. And the data will incorporate case or healthcare management notes, clinical data, and recorded services. And so at times there is going to be overlap between those proxies. And so our goal here really was to estimate the total eligible population and the amount of bookings for that population that qualify under each criteria. So importantly for this exercise, we're only interested in bookings that lasted more than 3 days, and this cutoff was determined by policy thresholds for which Contra Costa is mandated to deliver free relief services. And so let's talk a little bit about how we estimated the eligibility criteria. In this table, which as was mentioned earlier, y'all are all gonna get with the slides, you will find the CalAIM eligibility criteria and the proxy that we related it to in the Contra Costa health data. So for example, we interpreted that all bookings where a patient had a note from mental health services or patients in juvenile hall had a note from behavioral health services, they would be eligible due to potential serious mental illness healthcare needs. And so feel free to go to the next one. Now let's look specifically at the adult population. So here we take a little bit of a break from looking at the data from a booking perspective, and we look at it from a person perspective. And so in the data, there are a total of 24,845 adults from January 1st, 2022 to September 30, 2024. And approximately 60% of adults booked are between 31 and 64 years old. So we can see that between early adults and adults, we approximately account for 91% of the booked population. Next slide. So here we return to a per booking framework for the data. We were just looking at persons and their ages, and now we're looking at all bookings, regardless of whether a person was booked more than once or not. And we noticed that that bin that says fewer than or equal to 3 days, that is exclusive to those eligibility criteria, is actually the highest bin. And these particular buckets of days were chosen due to the different programmatic implications for length of stay. Depending on each length of stay bucket, there are additional requirements for CCH under the CalAIM Justice Initiative. We can go to the next one. And so we noticed earlier that the majority of bookings are 3 days or less. We also noticed that if you are booked more than once, the expected number of bookings will be at least 3. And this points towards an important recidivism dynamic. Out of the 42,375 bookings, only approximately 40% correspond to persons who were booked only once. And this means the majority of bookings in the data refer to persons the justice system will see at least twice, and potentially points towards high recidivism amongst a small but high need group. So for those who are booked more than 3 days, we also look at Medi-Cal data, and we find the slight majority of patients did not have Medi-Cal for the adult population. So recalling the recidivism slide earlier, we also did an exercise in the data where we saw that persons who were in their second booking had a higher rate of having Medi-Cal than those who were booked for the first time. And we can go on to the next one. So now the primary question becomes how much of that booking volume that we just saw will translate into pre-release eligibility under CalAIM. And so our answer is just above 2/3 of the booking volume we just estimated will be eligible. To be exact, 67.36% of bookings that lasted more than 3 days had at least one eligibility criteria. And just more than 40% of those bookings had strictly more than one eligibility criteria. And so while housing is not an eligibility criteria for the CalAIM Justice Initiative, we recognize that it can be helpful for holistic care management, and will also help determine some post-relief services. So notice that for the adult population, the eligible population is more likely to have a housing concern. And now let's take a look at the juvenile population. So here we see the age ranges for those booked in juvenile hall from January 1st, 2022 to September 30th, 2024. And we can see here that the majority of youth booked in juvenile hall are either 16 or 17, with 17 being the most frequent of the two. Feel free to go to the next slide. So there's a change here in the dynamic between the binning of the days, and we see that actually that bin that is fewer than or equal to 3 days is no longer the bin with the majority of the population. And this very drastic difference points towards, a different booking practice with the juvenile population. Feel free to go to the next slide. So notice here that there is a lesser concern regarding recidivism. Here we see that 191 individual youth are booked 516 times for an average rate that is lower than that of adults, but still at an average of 2.7 bookings per individual. Note that these recidivism statistics include the repetition of bookings that were potentially 3 days or less. And yet, when it comes to Medi-Cal, juvenile hall patients were also more likely to have Medi-Cal than not, with 56% having Medi-Cal at booking. So there is a smaller proportion of youth that have CalAIM qualifying conditions relative to the adult population. Approximately 55.24% of juvenile hall had a qualifying condition. Importantly as well, while in the adult population, most patients met more than one condition, juvenile hall patients were more likely to just have one qualifying condition. And so here we see that approximately 6% of all juvenile hall patients with qualifying criteria have housing security concerns, between 6 and 3%. And that would alter the ways in which they receive post-release services. Notice also the discrepancy between the rates that we saw for the adult population relative to the juvenile hall population. And I'll pass it back to Jamin.
Thank you. I just want to pause also to see if there are any questions on the data that Fabian just shared. And
Thank
also,
you,
as
Jamin.
Lauren said, they'll be sharing the slides out after. So, this is a lot of data. All right. All right, so a little bit about the service provider engagement. So the goal of our engagement process was to understand the real world challenges and opportunities in implementing the CalAIM JI. So over several months, we conducted 21 key informant interviews with stakeholders who directly shaped the pre-release and reentry services. Included in this group were justice agencies, behavioral and physical health, community-based organizations, and all of those are folks who are overseeing detention facilities, probation, ensuring continuity of care inside and outside detention, and supporting reentry through housing, employment, and case management. These conversations provided insights into service gaps, operational challenges, and opportunities for coordination. And we had a goal to focus on practical and actionable things. So next slide. So there were some key strengths that came out of our and So the system has several core strengths that can definitely be leveraged for improvement when implementing the CalAIM-JI. So the EPIC electronic health record system allows many of the partners in detention health, behavioral health, and medical teams to share patient data in real time. And folks brought up that having the same data infrastructure is really important to the continuity of care, especially for justice-involved individuals who often have complex health needs. And this ensures that providers have access to medical histories, which can help prevent service disruptions. Additionally, early engagement by detention health teams means that screenings for patient needs happen early and are documented. This can lead to warm handoffs to providers to reduce any gaps in care. And many agencies shared that this will hopefully improve post-release outcomes. Additional context that has lent to better has helped better the system have already been implemented. So for example, many people gave the example of AB 109, which really laid the foundation for integrated reentry planning by shifting responsibility for low-level offenders from the state to the county. And this policy change sparked innovative approaches and cross-sector collaboration, so that can make it easier to scale up the CalAIM Justice Involved initiative. A key strength that these attributes point to is that there is collaboration across sectors, so across justice and health and community partners. These folks already engage in multi-agency coordination and can lean on specialized teams to support the patient's needs. Additionally, as one agency partner shared in this pullout quote, people really care about this work. People's best hearts and minds want to see this come together. We can go to the next slide. So some of the challenges that were identified, I'm sure this is not this is not unique to this system, but staffing capacity, right? That's always an issue, staffing capacity constraints. Additional coordination barriers between justice and healthcare systems. So though there is that shared EHR, some folks don't have access to that due to HIPAA or due to various reasons. And so that coordination still can pose a bit of an issue. And then just the gaps that can happen at transition. And then as one partner put it, a whole person shock sets in upon release. Clients can lose access to housing, employment, and healthcare all at once. So it can be really hard for folks to navigate. And overall, the overstory that we heard from folks is that addressing these challenges requires investment in staffing, better cross-agency communication, planning. And then we asked folks to share about their future vision. So really, there's a unit vision for better system agencies. Agencies shared that it revolves around a coordinated person-centered approach that ensures individuals receive support at every stage of their reentry journey. And we have one more quote, and then I'll wrap up. Yeah, just the next slide. Great. So overall, folks shared, we have a strong foundation and a variety of resources that are integrated and coordinated across CBOs and county staff. And so the next slide just shares the steps for Contra Costa Health, which is that they will be working on capacity assessment and financial analysis, some program planning and design, and continued communications and collaborations. And again, as Lene shared, the go live date for Contra Costa County is October 1, 2026. And that's all we have.
Thank you so much, Jamin and Fabian and Lene, for this presentation. This was a lot of information, and really, we've been waiting for JI updates. And I think this has been really cool to see the process and then what happens moving forward. Thank you. Lene put her email in the chat. Yes, our time does not allow us to go into DXF, but please, if Jamin and Fabian, if you can put your emails in the chat as well, if folks have questions on this process or on the assessment that you did, if you're comfortable with that. So we will be moving past the data exchange framework, unfortunately, but we will come back to this conversation, I promise. So just in our, no minutes left. Leah, can you quickly launch the poll? We always want to make sure that we are being responsive to the collaborative. So please take a couple of seconds to fill out our poll. And as you do so, I will very, very quickly go through some updates. Oop, that's not it. So we know that we are changing the time of the collaborative meetings. So in April 18th, it will be the same day, but we're going to be moving the time an hour up. So it will be at 9 a.m. so that it does not overlap with CCHP's office hours. In May, we are planning to have an in-person collaborative meeting where we will do some dedicated data exchange framework discussion and questions. So we'll have Deanne do her DXF at that time. The date is not yet finalized, but that will come out in follow-up. And then moving forward, starting in June, our meetings are going to be on the second Friday of the month from 11 to 12. The updated registration link is posted in the deck, but we wanted to make sure that it didn't overlap with any office hours or any sort of standing meetings that CCHP or Kaiser hold. So we think that this day should work for folks' calendars. Please let us know if that is different, but those will be our times moving forward. And we, again, will send a lot of reminders. I'm sure you're sick of seeing my name in your inbox, but I will send reminders and follow up. Oh my gosh, upcoming events. HC2 is hosting their Calium Academy for Hospitals and Health Systems. Their webinar number 4 is coming up tomorrow. DHCS is holding a Managed Long-Term Services and Supports doula integration work group meeting on the 27th. And then again, are hosting their path-cited office hours until the application is due on May 2nd. I will stop there. Thank you so much for being here and for being here 2 minutes past when you were supposed to be here. Please let me know if you have any questions. Everything will come out in follow-up. Thank you again so much to RDA Consulting and to Lene for sharing about JI. And we will see you next month. Thank you so much for being here.
Thank you.
Thanks, everyone.